Hello and welcome back to Wellness Wednesday, a monthly educational series where experts share practical tips and techniques on the topics that are important to patients, survivors, and caretakers alike. I'm Erin Kuhn-Krieger with Ralph Pancreatic Cancer Foundation, and I'll be co-moderating tonight's session with Savina Chacheva and our partners over at the Cancer Wellness Center. Tonight, we'll be talking with Dr. Karan Dixit on a neuro-oncologist with Northwestern Medicine about Chemo-Brain. Before we get started though, I wanted to share that we are exactly 1 month away from Dash for Detection. We are so excited to finally get back together as a community to come together and be a part of this great program on Saturday, June 11th at Montrose Harbor in Chicago. But don't worry, if you can't make it to Chicago, you're not ready to be around others, we do have a virtual option called Dash at a Distance, in which you can do anytime in June. I'll be dashing in honor of a friend of mine who didn't make it. And for all of the warriors who I've met along the way and have been fortunate enough to be able to share their stories. But what am I really dashing for? I'm dashing for that piece of early detection research that will discover an early detection test so we don't have to dash anymore. Early bird registration ends on Monday, so check out the link in the chat and be sure to register. Okay, now back to tonight. For those of you joining us through Cancer Wellness Center, let me share a little bit about Ralph Pancreatic Cancer Foundation. We're a local Chicago organization with connections to some of the leading pancreatic cancer hospitals and organizations in the Midwest and beyond. Ralph Foundation provides personal and tailored support to patients, survivors, and families in crisis by connecting individuals with medical experts, personalized research, resources, and education, and we create awareness about risks and symptoms and fund early detection research. Our hands-on approach, or as we like to say, boots on the ground, ensures that nobody has to face this alone. So what does that look like? We personally and directly connect patients and families with medical experts and specialized resources that are tailored to their specific needs. Ralph funds research because we understand that the best chance of saving lives is early detection. And we provide ongoing education and support, like our panel tonight, to empower patients and their families to make quick decisions with confidence. You can learn more at ralphfoundation.org and connect with us through our social channels, and we'll put our links and everything in the chat for easy access. Now I'd like to welcome my partner tonight, Savina Chacheva from Cancer Wellness Center. Welcome, Savina.
Thank you for the warm welcome, Erin. As always, it's a pleasure partnering with you and Ralph Pancreatic Cancer Foundation. Good evening, everyone. Thank you for joining us tonight. For those of you new to the Cancer Wellness Center, I would like to take a minute to tell you about the center. The Cancer Wellness Center was founded in 1989 as a nonprofit organization with a mission to improve the physical and emotional well-being of those impacted by cancer and their families. Our services, which currently are both virtual and in person, include education programs like the one this evening that aim to help you navigate the varied challenges that come with living with a cancer diagnosis. Wellness classes like yoga, tai chi, meditation, stress reduction, and more that provide a holistic approach to healthy living, and support services, including counseling for individuals, families, and couples, children, as well as those bereaved. In addition, we offer support groups that are designed to help participants manage the mental and emotional impact of cancer. If you would like to learn more about the Cancer Wellness Center and connect to our free programs and services, please visit cancerwellness.org. The link will be included in the chat. Thank you.
Great, thanks so much, Savina. Now, a few housekeeping items for everybody joining us. If you have questions, please ask them throughout the session. We are going to save them until the end so that we can make sure that we get to everybody. So you can either send them by putting them in the comment section below, or if you want to send it a little bit more discreetly, you can email them to us at info@ralphfoundation.org. Tonight, we're happy to have Dr. Karan Dixit, a neuro-oncologist with Northwestern Medicine. Dr. Dixit's clinical interests include primary brain and spinal cord tumors and neurologic complications from cancer and its associated treatment. He has a specific interest in low-grade glioma, central nervous system lymphoma, and understanding the relationship between neurocognitive decline and longitudinal changes in structural and functional neural connectivity. Welcome, Dr. Dixit.
Thank you so much for having me. Thank you for the kind introduction. Nice to meet all of you. I'm just going to share my screen and then we'll get started. So this is a topic that's kind of been interesting, interesting to me, for the past few years, because just kind of understanding this process is very challenging for us as clinicians, especially for something that's very, very hard to study. And we'll talk about that in a little bit, because it's very hard to kind of understand kind of what people go through. So, without further ado, so what is Chemo-Brain? It's kind of a bit of a broad term. For some people, it may feel certain symptoms, and for certain others, we think a broader term, kind of more expansive term, more comprehensive term that we use these days is kind of a cancer-related cognitive impairment. That's a bit of a mouthful, or CRCI, the abbreviation. So we'll just call it Chemo-Brain for the rest of the talk, but kind of a more of a precise or kind of medical or scientific term that we use for Chemo-Brain is CRCI. The reason that Chemo-Brain is a kind of very challenging term is because it's a very imprecise term. It's for a very complex and we think multifactorial process. Again, like I said, there's numerous potential causes, and it impacts people very differently from one person to the next. One of the things that's been changing, over time, I would say over the past few decades, there's been a greater focus on understanding the relationship of treatments of cancer and how it affects kind of all aspects of life, specifically healthcare related quality of life, and one aspect of it being cognitive changes. Previously the thought was kind of dismissed, like, oh, you just have cancer, like it doesn't matter. But nowadays, as the treatments are getting better, people are doing better, these secondary effects of treatment and the cancer itself are being kind of focused on much more, which I think is really, really important, because the idea for treatment is to make sure we're thinking about a big picture perspective. And previously, one of the other thoughts from prior chemotherapies, the thought that how could that be causing these symptoms, is because the initial thought were, oh, these chemotherapies don't get into the brain, so how could they be causing neurologic issues? But as we learn more and more, the brain is not just an isolated organ; it responds to kind of everything else going else in the body. In addition, there are many other factors that can lead to cognitive changes. When it comes to cancer, it's not just the chemotherapy; it is brain radiation, even body radiation. Patients who undergo surgery. Hormonal therapy, people would have a lot of cognitive changes. We see that in other aspects of aging as well. Some of the medications that we use, in fact, many of the medications that we use can have side effects. And these are all probably all related. Some of the most common medications that we use, steroids, we use them very frequently. However, the more and more we learn, we realize that it actually has cognitive impacts. Pain medications, they're very, very important. However, drugs that we use like opiates, gabapentinoids, these can all cause levels of fatigue, and that can ultimately cause some, slight neurocognitive changes. Patients who undergo kind of really aggressive treatments potentially, such as bone marrow transplant, can also have cognitive issues. And then there's also, underlying mood disorder that can be associated with, having a diagnosis of cancer. So all things that can really kind of pile on and cause these kind of cognitive changes. And then there's also the disease itself. And I'll talk a little bit about that later on to talk. Is just, we know the body just responds differently when it's being, having to deal with the cancer. And there's some data and some studies that were done that kind of demonstrate that really well. We know cognitive symptoms are very, very common, and up to about 3/4 of people undergoing treatment have some level of cancer, who have some level of cognitive complaints. And, a third of patients feel similar symptoms even after the complete treatment. And as I mentioned, improved therapy has led to, longer survival, and thus people have the burden of some of these symptoms potentially for longer. And this table here, which I like, kind of looks at kind of different cancer types. The first one, the highest one is, brain tumors. It's no surprise that, people with brain tumors, 80+% have some level of cognitive complaints. That would be shocking if that was not the case. However, other more common diseases, such as breast cancer, lymphoma, colorectal cancer, 50+%, even 40+% of people can experience these symptoms as part of their treatment and part of their disease course. This is one of the most problematic symptoms, especially after treatment, that people, often I see, and we kind of talk about them. These are one of the most common symptoms that people have, one of the most problematic. The reason is because even mild to moderate symptoms can have a significant impact on, your daily functioning and this quality of life. Fatigue has a significant impact on these things. And then, when people try to resume kind of quote unquote normal activities, or resume work activities, the psychosocial impact of trying to resume these things, maybe before people are ready or before they feel kind of fully back to it, these things also kind of compound upon kind of the symptoms you're having. And then there's also the underlying anxiety, maybe the uncertainty for the future, that is also probably kind of going along with some of these symptoms that are kind of happening during treatment and kind of after treatment, and kind of really affecting people's cognitive function and quality of life. As I mentioned, that the symptoms can be quite varied. I think the most common symptom that people describe is kind of the very common phrase is mental fog. And that's a very, very kind of vague term, and it's very hard to quantify. Mental fog, it's something that people experience, but how do you really kind of study that? How do you really have someone explain what that means? A way we think about it is just kind of a slowed processing of information. Kind of just people just feel like when they think, things just aren't coming, or they're not processing things quickly. Someone asks you a question, and then you just have to take that extra few seconds to come up with an answer. Poor attention span and concentration. These are also kind of very, very common symptoms. And this and the next one, short-term memory impairment, these actually go hand in hand to a certain degree. You may know some people who have, what we consider poor short-term memory, but it's really just poor concentration. What I tell people is the phrase "in one ear, out the other." That's a real thing. So if your attention span or concentration is impacted for whatever reason, the information that is being given to you is not sticking long enough to even become a short-term memory. So, people say, well, and at home, my loved one is not remembering to, turn the lights off or do this. It's just because they move on and just kind of keep moving. And there's that idea just hasn't stuck with them, that they have to kind of stay behind and turn the light off. Or you ask them, hey, can you go to the other room and grab me something? And they walk in the room and like, wait, what am I doing here? It's just because that information didn't really kind of stick to begin with. Multitasking, planning, organizing, these are all interrelated symptoms that people experience. Cognitive processing, short-term memory, attention span and concentration. These all kind of coalesce to a certain degree. And another symptom people describe, which is a bit harder, for us as a neurologist, we have this word called aphasia, which is word finding difficulty, or kind of language disturbance, or dysphagia, which is a slightly less aggressive version. And one thing is word finding difficulty. I think everyone has word finding difficulty. I feel like I'm having it right now. And then this can only get compounded, during this idea of kind of Chemo-Brain. And these set of symptoms can really impact things like, difficulty with learning. Suppose you're in a job that requires a lot of rapid onset learning, or you're a student and you want to go back to school. All of these symptoms that people undergo can have profound impacts on these kind of these functions. It may take longer to complete tasks. And what happens to some people, expectedly so, is like these difficulties, people have anxiety about it. Like, hey, I'm unable to do this, and it kind of sometimes it's a spiral that occurs when people undergo these symptoms. The intensity of symptoms can vary quite significantly as well. Some people may be, minimally impacted, just feel like, perhaps they can, maybe they'll forget a few things here or there. Some people are unable to complete things that they used to love doing, such as reading newspapers, reading books. just kind of that difficulty with maintaining information, again, coming back to that concentration deficit, the concentration issue, can really impact quite differently for certain people. Like I said, there's many contributing factors, the chemotherapy itself, the actual cancer, your emotional functioning, your emotional flexibility, baseline function before diagnosis, baseline age, other medication that people can be on. And these, like I said, this spoke here is kind of a way where we think about all these things can have significant impact on cognitive function. When we think about how long people may experience some of these symptoms, it's one of those things that we learn more and more about it. It's important for us not to have like a strict timeline, because people think, oh, it's beyond 6 months, it's something else, or beyond this, it can't be chemo-brain. But the truth of it is, for many people, the symptoms can last for months, and for smaller percentage of people, it can last for even beyond. For the majority of people, these symptoms do slowly improve over the course of half a year to a year and a half. But up to 20 to 30% of people, or a third of people, can have kind of chronic symptoms. But what is important to know for most people, kind of ongoing treatment, the degree of symptoms is for most people quite mild. But mild for me may be different from mild for someone else. Any impact on cognitive function, can be quite distressing. And that's why we have to keep that in mind when we think about kind of how we think about this condition, basically. As I mentioned, this is kind of now kind of getting more into the what we think the cognitive science behind it. So the symptoms I mentioned, I was going to go back a couple of slides. So difficulty processing, attention span, short-term memory, multitasking. When we think about the cognitive domains that we think about learning and memory, we think about mental processing, attention, executive functioning, so cognitive flexibility, problem solving, verbal fluency. So, when we talk to some of our neuropsychology colleagues, these are all pieces of information that they're collecting, that we're kind of studying, is, how do people learn? How do you process information? How is your ability to process tasks that are given? So I don't know if anyone has undergone neurocognitive testing, but these are a lot of the tests that they're doing is to kind of specifically test out these cognitive domains. The challenge with ChemoBrain, however, is that, and there's been numerous studies that have shown that there's a significant discordance between the symptoms that people describe or experience, and then the actual findings of neuropsychiatric testing. Part of that is because, many of the symptoms are highly subjective, and then also many studies have demonstrated that there's not a significant correlation between objective cognitive impairments on neuropsychological testing. The biggest reason is because the testing probably is not sensitive enough to find some of these things. Are we asking the right questions? So like I said, the objective cognitive impairment, it does not correlate super well with subjective symptoms. And that's kind of what we see when we've kind of looked back at kind of ChemoBrain, kind of this cancer-related cognitive impairment, and some of the objective tests that we try to measure. And that's because even in other cases, neuropsych testing does not always translate really well to people's day-to-day functioning. And it tries to take into account certain things like fatigue and mood, balances of work and life and the demands, but it's very hard for an objective test to take into account all of these fluctuating, different and contributing factors into its testing. I spoke a little bit about how, emotional function, mood disorder, depression, anxiety, grief that people undergo after undergoing, having a diagnosis and undergoing treatment. These are all things that have significant function, impact on kind of cognitive function. Things that can also happen is just kind of people have a reduced frustration tolerance, so things that you could normally just cope with and things that you could compensate for before is just kind of gone, basically. A lot of it's also fatigue. A lot of the treatments that people undergo are just fatiguing. One way I describe to people is, imagine you haven't slept well, and your cognitive function, you just kind of feel like just can't get things. Imagine that kind of all the time. A lot of that can be caused by the treatments, not just physical tiredness or physical fatigue, but also kind of mental fatigue and cognitive fatigue. And these are all things that are very, very challenging for us as medical professionals to really kind of understand and study. And I'll talk a little about that in a second as well. So right now we don't have a great comprehensive assessment to kind of figure things out when it comes to kind of Chemo-Brain. There's no clear guideline for diagnosis. There's no like you have to meet XY criteria. You have to have this many symptoms to kind of qualify as having Chemo-Brain. There's no MRI image. There's no imaging correlates. There's no brain imaging that we can get. A routine image, I should say, that can look at brain lesions. In fact, it's one of the things we think about. Well, someone is having significant speech problems or language difficulty. And specifically that, well, is there something going on in the actual brain structure? But there's no CT or MRI finding that can say, oh yeah, your brain looks like this, so this is why you have these symptoms. There's no blood test. There's no spinal fluid test that we know so far that we can say, okay, yeah, well, your number is this low, so you have, this level of symptoms. More importantly, there's nothing that we can say, okay, well, it will improve over X period of time. It's very important for us as clinicians to kind of make sure we're looking at all the other contributing factors, blood work, people who have anemia can be very fatigued. Electrolyte imbalances, these are very, very important things. This is the reason why we get blood work frequently when you're undergoing treatment, because it can all have impact. People who have low sodium. Sodium is one of the most important electrolytes in the body. And then when it's too low, typically it's caused, or even when it's too high, but typically when it's lower, what we call hyponatremia, people can have tremendous cognitive impairments. In fact, if it's so low, people can have kind of difficulty with, speaking. People can have seizures if it's too low. Another thing that can happen is if people's blood sugar is too high. If people are really poorly controlled diabetes, people will come with active neurologic issues. Or if your blood sugar is too low, it can cause issues as well. A major thing that we're learning more and more, not just for Chemo-Brain, but I think in any kind of neurologic condition or anything kind of medical, we're learning more and more how important sleep is in good cognitive health. Any disorder that people have, and you throw in sleep disturbance on top of it, that's insomnia, parasomnia, sleep apnea, all these things can really impact these baseline issues. So trying to optimize sleep is a really important part of kind of something that, we try to do, something I try to kind of help people with. Baseline fatigue, like I mentioned, mood disturbances. If you've had prior brain surgery or other medications, all kind of contributing factors that we think about when we're trying to diagnose Chemo-Brain. A lot of what we try to diagnose Chemo-Brain is to rule out other things, because you have to rule out all the bad stuff. You have to rule out metabolic disturbances, masses, things like that. If all those are negative, then we have to think about, okay, well, that could be what's going on. Excuse me. One of the things that we do in the neurosciences is we think a lot about cognitive testing. How do you measure cognitive testing? So on the left here, these are some of the basic bedside testing kind of in the clinic that we can do. These are kind of short tests that are done in a relatively rapid fashion that are helpful to a certain degree, but these are good for looking at actual brain structural disturbances or something that's kind of like more of a neurodegenerative process. These are kind of helpful. So the MMSE is one of the most common tests that was kind of done very frequently. Is not being phased out, but is maybe being used less frequently now. We're using something called the MoCA. So the MMSE is this picture in the middle. So we ask questions like orientation, like where you are, what season are we in? Registration, so we kind of ask you to remember a few words and see how long can you remember them after a period of time. Attention concentration, this is where we ask people to do 0 to 7. We kind of subtract a certain number, like 7's the most common one, from 100. We ask people to spell the word world forwards and backwards being more important. These are somewhat helpful to kind of get a global sense, but it's not super specific. Okay. The MoCA, which is this picture on the right here, which is the Montreal Cognitive Assessment, is slightly more robust. We can maybe check a few more visual, spatial, and executive function. We can see how people name things, more memory testing, potentially more attention tests can be done. But these are only so good. These tests that we do may not be detailed enough or sensitive enough to find issues. And these kind of bottom 3 tests here, these are ones that we use frequently in neuro-oncology. And in many clinical trials that we do, we have kind of a certain set of memory tests, attention tests that are done, verbal fluency, how quickly can you find words. However, it's really important to know that even we know that these are not the best or most detailed assessments. These are kind of quick, crude things that we can do quickly and reproduce quickly. The unfortunate reality is we can't be doing, it's impossible to do full multiple hours long neurocognitive testing on every person who has a neurocognitive symptom, who's on a clinical trial. So we kind of have to find what is kind of a good battery of tests that we try to think about, that we try to do. This is kind of what makes cancer-related cognitive impairment very, very challenging to study. Just an agreement on the definition, the symptoms, and how does a clinical entity. Another major aspect is just the different types of tumors. Most studies, or the kind of the most robust set of data literature, is from breast cancer. Part of it's kind of just more common, but a lot of the work that was done early was very often kind of breast cancer. A lot of the treatments do include hormonal treatments. So we do know there's a component of hormonal treatments and cognitive dysfunction. And this is what people feel like when they go through menopause. There's like a cognitive change that happens during menopause. A lot of that's hormonal changes. A lot of the old studies that we look at, there's different studies, different scales. So for example, these are just 2 of many that we have used. One of the simple questions, well, what is a decline? Like how much decline is a decline is a real decline? Getting a baseline and tracking it over time is very, very challenging to do, but just because of fluctuations in time. One day you may feel better cognitively. If one day you may feel worse cognitively, is that the day you had the testing done? And how do you measure these slight fluctuations over time? So some of it's also changes over time. And there's differences within people. Different ages, education level, cognitive reserve. An 80-year-old will function differently than a 50-year-old. Someone who is a PhD in rocket science may have a different cognitive reserve than someone who doesn't have a PhD in rocket science. So that's what makes studying this condition very, very challenging, just given the heterogeneity and the symptoms, the tumor types, the treatments people undergo, the different ways to measure these things, and just people's differences, basically. Some of the changes, as we learn more and more about, neurocognitive function, that's also hopefully they're going to continue to improve and continue to yield kind of better results from our research. This is kind of a picture I like to show people. It's kind of how we think about the brain. So on the left is kind of like a picture, like frontal lobe, occipital lobe, parietal lobe, temporal lobe. The brain is way more than just these lobes. Colloquially, in a lot of our studies, we still think about that. We just still talk about tumors in the frontal lobe, or the parietal lobe, or the temporal lobe. But that's probably not enough. We're trying to move towards maybe a bit more of a nuanced approach to thinking about, okay, well, it's the dorsal frontal lobe. Is it the parietal lobe? These are things that can specifically, it's the prefrontal cortex. These are things that are much more involved executive function versus the occipital lobe, which is kind of much more vision. Temporal lobe is very much kind of, we think a lot of it's kind of memory. Then we have the deep parts of the brain, the limbic system and the fornix, and all these areas are important for attention span and concentration. And this is kind of as the field of neuropsychology and neurocognitive science is increasing. And I think we're moving more towards this last picture here, which is we know the brain is a connected network. It's not just one lobe, it's not just one part of the brain. Well, how does one part of the brain connect to the other part of the brain? And how does a problem in one area affect the other? Some things we know the brain has distributed function. We call this neuroplasticity, meaning that someone can have I'll use stroke as an example because I think that's kind of one of the more common things that we see, and some of the things you may have kind of experience with potentially with people is after a stroke, people have significant issues, and then it can take some time, but people do have some recovery, and this is kind of as the brain networks can kind of work around where some of the injuries are. We're learning more and more about the connections part of the brain that we didn't think that were the case. We thought parts of the brain that were not really involved in cognitive function really are. I'll use an example of children. Children can have a certain kind of tumor in his back part of the brain that we thought was primarily, just kind of balance oriented, something called the cerebellum. But certain kids who had surgery back there were unable to speak for a period of time. That's called mutism, or they had kind of cognitive issues. And this led to just the idea that this part of the brain that we thought was really not mainly for kind of just movement is actually highly connected to the frontal lobe, which is why people can have just kind of inability to initiate, inability to do some of these things. And this is kind of as we're learning more and more about the brain and its function, as we'll hopefully continue to expand our knowledge on how best to quantify and how best to study something as complex as Chemo-Brain. And this, I mentioned this earlier, and how can we even kind of test, brain function? This is an example here. It's a study done kind of many years ago where there were two twins. One twin didn't have cancer, and the other twin had breast cancer. It was treated with kind of the standard chemotherapies, like glufosinate, docetaxel, doxorubicin, and tamoxifen, a hormonal agent. And what they noticed in just the twin who had disease and treatment, this is a functional MRI where we're functional scan where we're seeing kind of like just brain function. So these areas where there's kind of these color changes are where there's decreased activity compared to the other twin. Why this happens, we don't know, but we do this kind of study, within two twins who would, as much as we can in science, twin studies everyone loves those because you have two people who should be as similar as possible, at least genetically and biologically. But even that's not the best, but there's only so much we can do. We can't clone people to do some of these studies. Now coming what we think some of the biologic basis is, because we know it's a thing, but what is really the underlying biology of what's going on? It's likely not one thing. I think that's one thing I think most people agree on. If it was one thing, it would have been found already, or we'd have kind of a better idea of it. And it's really multiple things. There's just kind of anything in science. It's never just one thing. It's multiple things going on all at once. One of the major components that we think is going on is neuroinflammation. And this is something that we're learning as we learn more and more about just neurologic disorders in general. Not this, but other things as well. As we learn more and more about dementias and things like that, all of this information that we're kind of learning from all these other fields of neurology are kind of being looked at in Chemo-Brain. So underlying chronic inflammation of the brain, cytokine release from the cancer itself, and that causes an inflammatory state. And the treatments themselves are likely having some sort of underlying inflammatory process. This can lead to oxidative stress in the brain, and this can cause direct injury to the neurons, to the underlying white matter of the brain. And then if the brain is injured, it has to repair slowly over time. And if you have kind of continued oxidative stress going on, there's not enough repair happening. It's inadequate repair of function, basically. The brain uses the nervous system, not just the brain, but the nervous system uses tons of neurotransmitters. This is kind of these small peptides that are used to carry information, all this information happening at 1 billion times a second all the time. And there's numerous neurotransmitters, choline, acetylcholine, norepinephrine, all these things that are kind of going around the brain and kind of helping kind of the communication happen. And so again, kind of coming back to other conditions, such as Parkinson's disease, we know it's a condition of people with decreased dopamine. Alzheimer's disease, we think partly is because people have decreased acetylcholine, neurotransmitters of the brain. And so the management of those conditions is to replenish or to give back those neurotransmitters, or to minimize how much they're being broken down by the brain and the body. So there's probably a component of neurotransmitter production that's decreased and secretion in the brain. That's probably also kind of what's happening. And then there can be damage to the blood vessels. And so the brain needs lots of blood to function. In fact, of all the organs in the body, the brain uses tons and tons of blood. So there could be some injury. And this is something what we do pick up sometimes on MRI. And it's something that we're learning more and more about is, people who have, really poorly controlled high blood pressure, who've had multiple strokes in their life. These are all things that can over time kind of impact cognitive function quite a bit. And we think this is just from what we call microvascular, where there's small blood vessels in the brain. They can just become damaged over time and just kind of basically robs that part of the brain from nutrients and oxygen. And so that's probably causing some level of function dysfunction as well. And so this is kind of where we think about the initial symptom. Set of symptoms are having from these kind of multiple processes leading to memory impairment, the cognitive processing that's slow, the language difficulty. And then unfortunately, that can lead to impaired quality of life, kind of work, education, social interaction can really be impacted. As I mentioned, we're learning more just from other neurologic disorders, largely from just one of which is from the aging process. As people age, they're changing the body and then the brain as well. So, one of those things is what we call neurogenesis or gliogenesis. These are formation of parts of the brain that are for function, neurons and glial cells. Glial cells being the parts of the brain that are used to kind of support the neurons, which are doing a lot of the processing. People who have hippocampal damage or hippocampal atrophy, the hippocampus is this deep part of the brain. So hopefully you can see my mouse moving around, which is kind of right here in this deep area. That part of the brain is really, really important for short-term memory formation. So people who have damage to the hippocampus, that can be from stroke, tumor, inflammatory conditions of the body, can have memory issues. One thing that my colleagues in oncology and radiation oncology trying to figure out, how can we minimize damage to these areas potentially. There was a good study, I don't have it on here, that was done by some colleagues at Northwestern from radiation, where they actually spared that part of the brain from radiation. And they noticed that people who had spared hippocampal avoidance of radiation had better memory outcome, because you're not radiating the part of the brain that can cause short-term memory issues. So by avoiding that can help. So trying to figure out some of these things is kind of really, really important. Something that happens as people get older is the gray matter, which is the outer part of the brain that holds on the neurons. We know as aging, and there's more and more kind of work being done on kind of what we call gray matter thickness, where we look at MRIs that we get frequently, and we see, is there actually a change in the thickness of the cortical gray matter? Is there decreased size of that over time? So does chemotherapy actually cause decreased cortical thickness? And does that cause just global dysfunction? Do you reduce memory, working memory, executive function? I mentioned the neurotransmitter aspect, like Alzheimer's, frontotemporal dementia, Parkinson's disease. These are all from reduced neurotransmitter function. And then the chronic inflammation that happens as the body ages, and that can just be the brain just cannot recover. Just keeps you have an injury, just can't recover because there's a chronic inflammatory state that's ongoing, basically. And then this is kind of what we think about. In comparison to other conditions, you think kind of from a conceptual perspective. You think about the active normal aging or natural aging. We do know that there's cognition that does decrease over time, and then we compare that to something like traumatic brain injury, which is kind of very, very sudden, from car accidents or what have you. That's a very sudden loss of cognitive function, and that improves some, but it never improves 100%. And then there's a kind of a slow trail off over time. That's in contrast to dementias, where in the beginning there can be kind of a slow onset for a few years. If any of you have known anyone with dementia, you'll have seen, or when you look back, things were kind of slowly developing, and there's kind of like a rapid drop off that happens, kind of as it becomes much more symptomatic. And then we think about look at ChemoBrain. So you think about just the timeline, which is kind of right here on the right. You think about, okay, you have a normal baseline, pre-diagnosis, then you undergo treatment, and that can cause this kind of acute decline in function. And then as the treatment ends, there's kind of hopefully stability. And then as we kind of as we move from over time, that there's some slow recovery. But then as the brain, as the body ages, that there's going to be, expected changes with that. I wish I could tell you there's always going to be improvement. And so this is what we're trying to figure out. How can we, one, reduce the acute toxicity that happens with treatment to minimize that drop? Or is there anything we can do to enhance recovery? What can we do that kind of makes this delta curve go up more rather than just kind of stay horizontal and kind of go down further? Some risk factors that we think about, I mentioned that, very, very person dependent. As people get older, and it's not the brain, it's the body in general. Cells develop damage to DNA. It's going to accumulate time and time. There's in the news, there's been talk of telomere shortening. I don't know if people have read about that. Telomeres are kind of the end of the chromosomes. And as people get older, those get shorter and shorter and shorter. And that's, we think, is one of the major aspects of aging. As people get older, there's more and more chronic inflammation. And as people get older, there's fewer cells left for repair. So I think part of it is just age. Are there some genetic components? Something called ApoE, which is can be impacting people who have Alzheimer's. And then we think this may be impacting people who have poorer or less flexibility or less recovery from brain injury, from high blood pressure, or neuronal processes that can't be repaired as quickly. And so this is people who have impairments in this ApoE4 are seen to have kind of lower cognition in people who have kind of brain injury, basically. COMT, this is an enzyme. They treat this in people who have Parkinson's disease. It's catecholamine methyltransferase. I actually forget the full name of it. This is really important for dopamine. So people who have impairments in this may have just lower dopamine function in general, which is an important neurotransmitter for kind of cognitive functioning, for planning, and for initiation of activity. And that can lead to lower dopamine in the frontal part of the brain, and that can just cause, difficulty with performing poorly in cognitive tasks. And then, as I mentioned earlier, just cognitive reserve. What's your baseline function? There's a variety of kind of baseline intellectual function, education level. If you've had a prior stroke and then you have a cancer treatment, there may be kind of other things to kind of recover from that can be a bit more challenging. And so there's all of that going on, like all that science. How do we figure this out? What's actually happening? But how can we try to manage this? And what are some strategies that we can talk about that may help? Some of these are actually very common sense. These are things that people probably just do naturally. But I think sometimes it's helpful just to kind of like to sit down and talk about it. Say, oh, I haven't really tried that, or that's a good idea. Maybe I haven't done that. I haven't done it that way. The truth of it is, because this is such a complex issue, there's no pill. I wish there's a pill I could give which kind of fix all of this. I don't think there ever will be a pill that can fix all of this. There's no single one strategy either. It's not like if you write things down more, it's going to naturally fix your memory problems. Unfortunately, it won't be like that. But it's more, what are a set of tools that we can talk about, a set of tools we can provide that may help kind of coping with some of these things and strategies to manage them. But the most important thing is to tell your team, whoever you're seeing, if you're having issues, don't feel like it's normal. It's common. If it's really affecting you, or if you're feeling it, cognitive issues, just tell your team. Let them know, like, hey, I've noticed I'm having difficulty with cognitive function. This may lead to testing, and hopefully will lead to testing. At least kind of basic blood work and whatnot to kind of rule out the more common things that can affect these things. Because there's many things that can cause reversible cognitive issues. I mentioned this earlier, but anemia, electrolyte imbalance, thyroid dysfunction, which is very, very common. And we're seeing more and more of that. Vitamin deficiencies. And these are all things that can really kind of impact baseline cognitive function. Many people who have been diagnosed with cancer just aren't tons of medications, and then it makes sense. You're having symptoms. We want to do everything we can to help them. And if there's something like pain, we give medications for that, but they all have side effects. We sometimes put people on, medications for nausea, certain times. These are all things, or kind of dizziness. But these are all things that can actually kind of depress neurologic function sometimes. So sometimes cleaning up the medication list, medications for anxiety, these can all have lots of cognitive impacts. So just cleaning up the medications if possible. And then identifying factors that can be modified. If it's poor sleep, that can be modified. We can, if it's really severe, we can have you see one of our colleagues in sleep medicine. If it's mood changes, we can try to see, will cognitive behavioral therapy help? Will a therapist help? If it's pain, actually uncontrolled pain is a major aspect of cognitive dysfunction. In fact, this is something we see in people who are hospitalized or maybe unable to speak and who may be confused all of a sudden. We try to find, is there something causing pain that can cause it? So these are all things that we ask people to do, but also to be mindful of your own self and your own ability. To cut yourself some slack. Of course, high functioning people always going to be functioning at that high level, but just know there's fluctuations, just know the other things that can change over time. Just cut yourself some slack basically, because over time things should hopefully improve. And so we talk about some of the compensatory strategies that we discuss and some lifestyle changes. It sounds silly, but keeping a positive attitude can be helpful. I'm not someone who likes platitudes. I do like to be, it's important to be informative and realistic. It's not one thing is, keep a positive attitude, everything will be fine. It's not as simple as that, but as a starting off point, it's helpful, to kind of have the motivation to kind of work through a system. And that's hard to do if mood is impacted. It's easier said than done. Nothing bothers me more when people are saying they have mood issues and they're saying, oh, just kind of think positive. That's not how you manage it. There are things that we try to kind of work together, and this is a process of improvement. It's not going to be one day you're on a medication or one day you kind of do this and things are going to get better. It's a process system that takes time. So that's the main thing, to develop a system, to create routines. Routines and systems are much more deeply integrated than memories. Once you do things over and over again, it becomes part of your lifestyle, it becomes part of your daily practice, basically. Certain things, people misplace things very frequently. And for people who do that, and that happens as part of Chemo-Brain, people kind of have the sense of needing to know where everything is and they lose things. Keeping a system, keeping all the essential things where you need them to be. Same place, all the time, no differences. Medications, I just saw someone yesterday who were trying to use a stimulant medication to take their morning dose all the time, but they always forget their afternoon dose because it's in a different location for whatever reason. They keep the morning dose in the bathroom, but then they keep their afternoon dose like somewhere in the kitchen, basically. But keep your medications all where they need to be so you can kind of get back to it. All the things you need, your wallet, purse, keys, all these things, just keep them in a central place that they're always there. Memory aids, notes, notebooks, these are all really important. Avoid sticky notes, you can lose them. Again, that sounds silly, but that's an easy thing to fix. Another thing is, if there's a task that has to be done, especially a complex task, try to find ways that you can maybe divide them up into smaller steps, because it's easier to deal with something smaller chunks than like a big task. And that way, after you finish the smallest task, then you can kind of check it off, feel accomplished, take a break, and then move on to the next thing potentially. Again, like I mentioned, cutting yourself some slack, you just got to recognize that things will take longer than they used to, or they may have to be done differently. You may have to, if at work, you may have to schedule meetings at different times potentially. And you may have to spend more time on something. You may need to kind of have, people repeat things. And, it's okay to ask someone like, hey, can you speak more slowly? I should speak more slowly. If you're meeting new people, you can let them know like, hey, it may take me a little bit more time to remember your name. So don't, never apologize, but you're like, hey, just kind of say, this may take a bit more time than it used to. When you're in a new area, it may take you more time to navigate a new area. So, just kind of make sure that you kind of give yourself some of that allowance when you're exposing to something new potentially. Try to avoid multitasking. If someone's tired or not doing as well or not sleeping as much, you try to multitask, everything can fall apart. And that's even without Chemo-Brain. So, avoiding multitasking can be, quite helpful. Try to minimize distractions as much as possible. Get easier said than done. I mentioned this a second ago, but take breaks. If you complete something, if you take a quick break, that may help kind of just give you the bit of a rest you need, and then you can kind of regroup and kind of continue what you were doing. Checklists are super important. This is something that I've realized more recently. If I don't have a checklist, nothing will get done. So checklists and priority lists. If you have a checklist, how to make a priority list. So if something has to be done, you put it at the top. And if you do this over and over again, this will hopefully help some of the kind of the routine part of it. And then at the end of the day, you review your task and see what was done. If you're noticing that there's something that's not being done routinely, then are there anything that you can kind of potentially modify in your routine? When we talk about memory compensation, when I think about memory as a neurologist, to me it is the initiation of memory, the storing of it, then it's the retrieval of it. This is what I mentioned earlier about that in one ear, out the other kind of thing. How do you acquire information? How do you acquire something? That concentration is really, really important, which is why focus is super important. And this is why one of the things I'll mention a little bit is, there's not a lot of drugs we can use, not a lot of medications we can use, but there are some things that can be helpful if focus and concentration are primarily affected, which is stimulants basically. And I mentioned this earlier, but just ask for the information that's being given to you to be delivered more slowly. Reread things over and over again if you need to, and that's okay. So just kind of the acquisition of information, just do it more slowly potentially. And then to store and retrieve it, if you have, tricks to links a piece of information to something that's meaningful, organization of information is helpful. And sometimes mnemonics can be helpful, for certain things, not always, because you got to learn the mnemonic, which is sometimes challenging to begin with. So these are all kind of tips and tricks that can sometimes help with kind of primarily memory disturbance or cognitive concentration issues. I have referred people certain types of cognitive rehabilitation. It can help. I wish I could tell you it was the thing that would fix everything. Not always the case. But around Chicagoland, there are a few centers that have some cognitive therapists, either occupational therapists or speech therapists, who can work with people who have kind of primarily cognitive disturbances that can be helpful. One thing I mentioned earlier in the talk is that neuropsychological testing, we do it, but doesn't really show anything. Your medical team can maybe hopefully talk to you in a bit more detail if neuropsych testing is indicated. It often isn't for people who have Chemo-Brain because the testing we do doesn't really show up. But if we're noticing that you're having kind of more profound symptoms than we would expect, then we sometimes can pick up some things in neuropsych testing. We can sometimes see, what your baseline function is. We'll try to glean as much as possible through normative data, like your age and education level, things like that. If we're noticing that a lot of it's mood disturbance, we can sometimes pick that up on neuropsychological testing. If we notice the pattern of cognitive dysfunction is primarily attention span rather than executive function, then we can focus your therapy more on concentration and whatnot. So neuropsych testing can be helpful, but sometimes it's not. So your medical team will be the one to kind of guide and let you know if it's going to really helpful or not. One thing, again, easier said than done, is to keep the mind stimulated. Try your best to stay active. Try kind of mental exercises. People try. Do they do much? We don't really know. It's very hard to study. And then socialization. That was hard to do. Hopefully, as COVID is kind of, I'm going to jinx it, but hopefully things are kind of fine again at the point where hopefully we can kind of get out and do things. I think this is quite helpful. Again, I don't want to keep talking about the patients I see, but there's, again, I see brain tumors all the time. So people with a lot of cognitive issues. I'm talking with someone who, when they're here, they're not doing too much, but they went on vacation or they went on a trip and their spouse is like, yeah, it was fine. No issues. That's because it's not just the travel. It's not just going someplace. It's just being stimulated. It's kind of that stimulation, that kind of, that positivity can sometimes kind of give that a lot of energy. And so, as much as possible, these things can be somewhat helpful. Some other simple things, or seemingly simple, we do know, again, extrapolating from other kind of conditions, try to stay as regular physically active if possible. I know that may not be easy. People can have weakness from treatment. People can have nerve damage from treatment. That can make it harder to walk. That can make it harder to do things. But as much as it's kind of safe and medically feasible to do, regular exercise is important for cardiovascular health. That can improve brain repair after injury. Cognitive function, people can feel better in general. We think people who have exercised more regularly can have better kind of brain connections. The low impact exercises can be thought about. Fatigue can be a bit easier to deal with if you kind of stay regularly active. And we do know more and more that staying regularly active, people can have lower stress levels. So, as much as possible, a regular physical exercise program can be helpful. I've spoken a few times about restorative sleep, and that is really, really important. Sleep deprivation can really impact poor healing. Sleep is really, really important because this is kind of when people really consolidate memories. This is really important to organize the mind. If you're not sleeping well, your mind can always feel jumbled, basically. And poor sleep will lead to daytime fatigue, and that can cause impaired cognitive function. Things that you can do kind of quickly or easily, again, like I said, a lot of these are very kind of common sense to a certain degree. Avoid stimulants, avoid caffeine before going to bed, avoid high sugar foods before going to bed. Try to maintain good sleep hygiene. So before going to bed, turn the lights off for like 30 to 60 minutes. That's your phone, TV. Like people are on their phone until they're going to bed now. And that can actually, your brain just doesn't shut off in time. Relaxation techniques, try to maintain a regular bedtime. Try to go to bed each night. So body kind of needs that level of regularity. As much as possible, kind of 6 hours of sleep. It's not the number per se, but it's not the quality of sleep. If you're sleeping 8 hours, but you're waking up 5 times a night, that doesn't mean anything. And it's not like you have to have a minimum of 6. It's just, some of, we say 6 to 8 hours of sleep as much as possible. But if you are waking up at night, let's say frequently, let's just say it's because you're having a lot of urination issues or you're having pain that's waking you up. These are things that can sometimes be actually helped with medicines or medically that help sometimes. And the good nutrition, of course, that's simple, right? It makes sense. Like a balanced diet, low in sugars, high protein, low carbohydrates as much as possible. We think maybe antioxidants may be helpful in minimizing some of these issues. Again, there's not a lot of good data on it, unfortunately. I wish there was. Multivitamin can't hurt. That's not really a medical strong advice, but can't hurt. So take a multivitamin. I mentioned this earlier, but kind of maintaining, kind of engaging in positive and stress-reducing attitudes, these can be helpful. Again, easier said than done. We don't want to kind of make, like I said, I'm not a fan of platitudes, but as much as possible, as much as your life allows, the people you're with, as much as you kind of have as much of a stress-free, positive environment as you can kind of create around yourself. Psychological therapy. We know more and more. Mood disturbance, bereavement, grief, depression, anxiety can really undermine people's cognitive health, and it's very often that it coexists with the diagnosis. It would be impossible to expect otherwise, and these symptoms can be worsened by the treatment. So, like I said, let's make sure your team is looking at the medications you're on. You need to be on certain stuff. Supportive health can be quite helpful. And then if there's medication, if we don't want to default to medications, but things can be added if needed. I mentioned this earlier, but drug therapy, there's very limited options. However, in people who have kind of primarily attention or concentration deficits, frontal lobe issues, sometimes Ritalin can sometimes help kind of cognitive function in certain cases, certain people, not for everyone. If it works, it works. If it doesn't, it doesn't work. That's what I tell people. You start it off, you do it for a few days. If it doesn't work, it's not going to do too much. It's not a drug that you need to take frequently to see if it does anything. Either it does or it doesn't. There are drugs that are being studied for wakeful agents to see if they help cognitive function. There's still data that is, we're looking at all these things. It's not really kind of positive or negative yet, so we don't know. Neuroprotective drugs, again, haven't really been well studied. People are seeing, can you repurpose drugs used for other conditions like, donepezil, memantine? These are things that are used in Alzheimer's disease. Does vitamin E do anything because it scavenge free radicals? We don't know. This comes down to the difficulty in studying this condition, basically. So, what are some of the future directions? Like, how can we think about this, and how can we move forward as a field, basically? Right now, as we know that there's different regimens, different chemotherapies, and different mechanisms of brain injury that can potentially happen. how does this affect, the cellular process in the brain, and how does this impact cognitive function? Right now, a lot of it's kind of very symptomatic management. A lot of pills are being kind of thrown at you and things like that, or all the things I've mentioned. It's all symptom management. But what are new approaches? Can we repurpose drugs that we use for other things? Can we try to figure out, well, what is the actual underlying basis for chemotherapy causing nervous system inflammatory changes? And is there anything we can give along that time to kind of decrease that to a certain degree? There's studies being done where they've tried things like lithium, they've tried some blood pressure medications, Ramipril, some diabetes medications, pioglitazone. The idea is this kind of less? Is it less inflammatory or anti-inflammatory? Does that lead to less oxidation stress? For people who've had kind of chemotherapy, they've tried fluoxetine, so it's an antidepressant, ibuprofen. Nicotine. So there are ongoing studies, and none of these have really resulted yet. But again, the idea is, can we kind of look at drugs that can minimize oxidative stress, to promote neuronal function, neurogenesis, improve neurotransmitter function, and try to figure out like other risk factors. Can we identify risk factors that say, let's say we have an 80-year-old with certain things, and we can say, well, your risk of brain fog or Chemo-Brain is going to be higher than the other person. Other imaging biomarkers, can we do functional MRI? Can we do these things kind of help differentiate and diagnose this basically? So thank you for your time and attention. And if you have any questions, I'm happy to take them. I think right on the hour.
You are very timely. So thank you for that. And thank you for normalizing this first and foremost. We're going to open up for questions, but so many have come in already. So I want to get started. Please, folks out there, continue to ask your questions. We're going to keep going with it. And you can do that in the chat. You can send us an email at info@ralfoundation.org. If you have a question and you need to head out, we are recording this session tonight. We'll be sending it out. It'll also be on our website. So we will get to the questions. Okay. So let's start with anxiety. And you talked about anxiety impacting Chemo-Brain. Can you talk about stress as a factor as well? I would imagine, on that stress note, have you seen an increase in Chemo-Brain and the emotional factors surrounding it during the pandemic, with everything being so uncertain and all the added stressors?
Oh, absolutely. I talk about, even like before the diagnosis, anytime you were stressed, you felt that in you, right? People felt when you're stressed, your body doesn't function well. Imagine that on top of going through everything. So absolutely, and then, that's why, to normalize this, but also to, again, like I said, not platitudes. I mean, it's hard to remove stress. You can't say, just live a stress-free life. But yes, absolutely. Life stressors, can really impact function quite a bit. We've seen many people, especially earlier during the pandemic, where you couldn't get out. Even coming to see your doctor was challenging. Seeing your friends, and we saw kind of a major drop off in people's kind of mood and kind of just function during that. So absolutely, stress has I think a major impact on kind of all body functions, specifically cognitive functions, and the stress and anxiety. I think it's really people can kind of go into kind of major spiral. That's one of the things is, to make sure your team, there's people out there to help with some of these things as much as possible. But, absolutely, those can really impact kind of cognitive function. But those are hard to remove. We can't remove the pandemic and we can't remove stress. So, yeah.
Okay. Can you define cognitive reserve, what that means?
Yeah, that's a great question. Cognitive reserve is a term that we use a lot of time in here's not the nicest thing to say, but let's just say someone has, let's say, years of alcohol use and drug use, and they come in with a brain injury or a stroke or a seizure or a brain tumor. We have an expectation that they may have harder time to recover from someone who's lived a life of exercise and living healthy and like that. It's a term that we can't quantify. Like, we just have to have this sense, like it's an 80-year-old who's with a history of alcohol overuse versus someone who's not. people who kind of have poor, what we say, cognitive reserves. So cognitive reserves is a term that we use for what we may think medically, that your ability to maybe tolerate some of the treatments, like radiation to the brain. Like this is an example that comes day to day in my practice. We see someone who has a brain tumor, who has prior brain damage from stroke or something, then we think about, well, can we actually radiate that part of the brain? Is that person going to recover faster than someone who hasn't? Like we see the people who've been smoking, for the whole for a lot of their life. The brain actually can have blood vessel damage. This is where imaging can be sometimes helpful in people who have cognitive issues, to see how much brain injury there is. This is where it comes down to the MRIs, what they're good at showing, but what they don't show. Cognitive reserve is a very vague term that we use, and it's different from when I think about it compared to someone else. But it's basically the way that when we communicate to our colleagues is, what are thoughts of kind of what we think their brain health is pre-morbid, like what we think that they can tolerate, basically. And I guess this is why some of it's just based on their prior, medical issues, their lifestyle, things like that.
Okay. Can ChemoBrain cause disequilibrium?
I would say that's disequilibrium that's another hard thing neurologically to kind of quantify. I would say that's not the most common symptom. I would say that most people don't come to me with that. I would say ChemoBrain is more kind of a slow processing. Disequilibrium can be from inner ear dysfunction. That can be from nerve damage in your feet because the walking is off. Disequilibrium can be from underlying brain injury. I would say that's probably not the most common symptom that I would associate with ChemoBrain per se. People can just feel unsteady, like after treatment, like if the blood pressure is low, they get up and stand up, they feel kind of like wobbly, potentially. But I would say that's the most common symptom people describe.
Okay. If you have other underlying medical issues that cause inflammation, does that increase the ChemoBrain as well? And does it lead to an increased time of healing?
That's a good question, actually. That's something that's something that can be studied a bit more easily when I think about it. Like, for example, I'll use like rheumatoid arthritis as an example, or kind of a rheumatologic malignancy, a rheumatologic disorder, where the body is in an inflammatory state. The main treatment is corticosteroids or whatnot. That's a good question. I would imagine that perhaps there may possibly be a bit more maybe a slightly higher risk of developing ChemoBrain if you already have potentially an underlying inflammatory process been ongoing in your body for many years. And that may impair the ability for the brain to kind of like recover and kind of heal over time. But I don't have a good kind of a solid scientific answer to that, but from a logical perspective, I would say that makes some sense.
Okay, so going on the inflammation front, and you talked about the importance of eating healthy. So last month during our Wellness Wednesday, we spoke with a nutritionist about a cancer-free diet where she focused a lot on reducing inflammation and the benefits of a non-inflammatory diet. So following this type of diet, like a Mediterranean diet, non-inflammatory, I cannot speak tonight, inflammatory diet, would that be helpful in terms of easing or lessening the impact of ChemoBrain?
I think it wouldn't hurt. That's one of those things, that question is something that would be great to answer as part of a study. And they have done that in other conditions, like, Mediterranean diets and other things. And we've seen improvements in most of the studies in kind of other conditions. So I would say that's probably a fair thing to try. I don't think it would cause a problem. To say, will it cause benefit? That's harder to say, but it certainly will not cause a problem, I would imagine.
Okay. Have you seen that caretakers or loved ones experience a similar brain fog, or perhaps a caretaker brain?
Yeah. I mean, when we see people in our practice, we know the disease not just affects the person, but also the caregivers. Sure. I mean, a lot of that's just from the caregiving. It's a fatiguing process. Absolutely. I mean, caregiver fatigue is real. That's why part of it is to kind of make sure that, again, it was easier said than done, that the caregiver also kind of focus on themselves to maybe minimize some of these things. But I mean, I'm sure, caregivers aren't sleeping because they have to worry about their loved one having a medical issue. I mean, I'm sure these things can really kind of compound on someone. That's kind of just from more of a general health perspective. So I would imagine so. I've not asked directly, but I can see it in their eyes.
And so it would be reasonable then to say that following the suggestions that you gave would be beneficial for caretakers as well.
Absolutely. Yeah. I mean, especially good sleep as much as possible, healthy diet, things like that. Absolutely. I mean, some of these things are just for like as a neurologic health in general.
Sure.
Yeah, these things aren't specific to Chemo-Brain. It's just kind of what can we do for anyone who has some set of cognitive disturbance.
Sure. You talked about sodium. Would drinking beverages with electrolytes be helpful?
You know, I mean, I think staying well hydrated is really important with like proper hydration. I mean, I probably can't hurt another thing. There's probably nothing that can't hurt, but you know, I'm also one that if someone's trying to sell you something, you know, good old fashioned water is way cheaper. Does electrolyte water actually have a benefit? You see it on the stores everywhere. To me, that seems like someone trying to sell you something. So I'm always a little cautious about that, but it's probably not going to harm you. Absolutely. I mean, when I worry about sodium, I'm talking about when it's actually low, when the actual blood value is low. That can cause actual neural dysfunction because your body uses a lot of sodium to actually have all your neurons work. So if the sodium is actually low in your blood, that's a problem. But if it's kind of normal, I don't think adding salt water is going to make you function better, or that will make you kind of function better. But staying well hydrated is really, really important. I should put that in my slides for next time. Is staying hydrated is really, really important because dehydration can really make anyone feel crummy.
Yeah.
That's actually really important. Yeah,
Absolutely. So what advice do you have for those in our community who get frustrated trying to explain that Chemo-Brain is real? Or what if their medical team dismisses them and this idea? What would you say to that?
I mean, I'm hoping at this point people don't do that. I mean, I think there's enough data, a body of literature out there to know that it is. I mean, it's one of those things just because we don't know the reason of it, that it's not real. You know, back in the 1800s, we just assumed all psychosis was something like, you know, humors of the body, basically. But we know that's not the case. We know there's something underlying these things. So, I mean, at some point, hopefully in my career time, we'll get a better of a biologic sense. How to address people who, I mean, again, easier said than done is maybe let it roll off as much as possible. Maybe not get into it, but if a medical team doesn't believe it, I mean, I don't know how to say this without coming off as being disrespectful to them.
Find a medical team?
Yeah, maybe. Or, you know, or just kind of maybe ask for resources like, hey, you know, perhaps you might be helpful with this, but do you have any resources that you can kind of reach out to in the community who can maybe help? So there's organizations like yours, to find a community of people who do kind of understand. So I think that's helpful. Yeah, I mean, I really, at this point, I don't think anyone, as people who I work with, dismiss it. It's just the problem is we know, I wish there's something we could easily do about it, right? You know, I wish we could do something easily. I think that's one of the things that people may get that kind of like brusque response is because, well, I can't do anything about it. Why are we talking about it? I think that's probably what people are experiencing rather than not knowing it's a real thing. And it's true. I don't have a great medical option, but it's trying to find all the things. I mean, ruling out the other stuff is actually a major part of the treatment, you know? Yeah.
Okay. Does the type of chemo that one receives affect the type, or if they'll have Chemo-Brain?
We know endocrine therapies can have kind of that, especially like tamoxifen. That's one of the more common things. One of our test questions actually is, you know, they give a list of drugs. What are the ones that cause cognitive issues? Things like tamoxifen can, to a certain degree, in certain people. High dose methotrexate. This is a drug that is neurotoxic actually. So certain chemotherapies can be neurotoxic. Methotrexate's one of them. In fact, I see many people, because we get that drug because it gets into the brain really well, and who've had like pediatric treatment, they got that drug into the spinal fluid. There are tons of brain injury just from it. Certain drugs that are used for like lymphoma, fludarabine, cladribine, busulfan, these are some drugs that can potentially increase risk of cognitive disturbance. Maybe not chemo because it's actual brain damage from the treatment potentially. And those things we sometimes see on the imaging sometimes. Like I said, a lot of the treatment, a lot of the research is done in breast cancer, but is it drug specific or just kind of the regimen that you get? But those drugs I mentioned are, I would say, the ones that are kind of ones that I see frequently people have cognitive issues with.
Okay. So is it common for those who used to be good at multitasking to have problems doing more than one thing at a time after chemo?
Absolutely. I mean, I think anyone, I would say that's very, very common. And so that's one of the things is to kind of like this had the expectation to a certain degree, and then like allow yourself the ability to kind of like, work through it.
Sure. So I'd
Yeah.
imagine that those experiencing chemo-brain may be resistant to acknowledging it or wanting to help or to change patterns, perhaps even thinking, why me on top of everything else? Aren't I dealing with enough? How can caretakers help kind of normalize it and help them implement lifestyle changes for what the patients are going through?
Yeah, a lot of the things we see for caregivers is because I think it's a sense of losing independence that people feel. They feel like they're not the person they used to be. Some for the caregivers is to kind of, as much as it is to allow that to happen a little bit, it's kind of like not be always like immediately there, to kind of allow that, just kind of be there to say, hey, I'm here, ask for help. As long as it's a safe thing, when you'd be getting up to walk, if you can't, going to fall over. So that's a bit different. But for caregivers to kind of give that space, for the person going through it, to kind of work through it kind of at their own pace, basically. Because over time, I think there's a bit of an adjustment period to kind of going through it, where it's like anything that happens to anyone that's stressful or going through something, you have to experience it. Then you kind of like, this is kind of what it is, and you kind of work through it. And then it comes to you, how can you internally deal with it? So for the caregivers to kind of be that resource that like, hey, I'm there for you. Let me know how I can help, and not be like, okay, let me do this for you. Let me do that for you. But again, every family dynamic is different, So that's the one thing for caregivers is they're caregivers for a reason. But sometimes people just need to kind of work through what they're feeling kind of on their own in the beginning. And then they'll let you know, okay, hey, this is kind of what I need you for. This is where I need your support. This is where I need your assistance, and then kind of be there to help with that.
Sure. I think that that's a great point, to allow people to get it, to feel it and be in it, and then let you know what they need to be able to move forward. So we have two questions left. Our next one is, which is better during chemo, traditional meds versus cannabis?
I wish I could answer that. No, because a lot of it's, I mean, as you know, medical cannabis, many of the people I see use it. We can't study it, kind of still federally illegal. So to study and research. So a lot of just anecdotal. And I want to caution and not use a lot of anecdotal evidence when I kind of answer some of these questions. What I would say in kind of anecdotally, medical cannabis at the very least is not dangerous. It doesn't have too many side effects. I think many people can just kind of tolerate it. Medical cannabis maybe a little bit better than some of the other medications, like things like Zofran or things like for like nausea, can actually have other side effects, like headache and constipation. And medical cannabis may not have some of that. Anxiety management, the medication we use like alprazolam, Klonopin and other antidepressant anxiety medications, they can have other side effects, and sometimes cannabis does not have some of those. But the problem with cannabis is because it's not well studied. You can't guarantee that one batch is going to be the same as the other. As far as we know, we can't prescribe cannabis. We can just tell you have a condition where you can get it. So part of it's just because of the lack of standardization. It's very challenging. But I have many people who try medical cannabis and say, "Oh, this is way better than what I was doing before that you gave a prescription for." I'm like, "Fine, great. That's no problems with that." So it's also make sure your team is like, supportive of that kind of those ideas. Because I'm glad that these past few years have been kind of much more, at least in Illinois, it's much easier to it's much more acceptable, I should say, for using medical cannabis than things used to be. So I think over time people will use that more. But it's hard you can't compare them side by side.
Sure, of course. So my last question is, what are the top 3 takeaways or top couple takeaways that you want our community to walk away with tonight?
Yeah, great question. So one, that ChemoBrain is real. It's a thing that you experience. There's many causes of it. And then to kind of cut yourself some slack and kind of slowly work through kind of mindfulness exercises, and to kind of have kind of basically breaking things down in shorter steps. So I think that's the main thing that people experience during Chemo-Brain is this kind of poor concentration, attention, multitasking. Those are kind of the big things that I see people experience. So to kind of break tasks down in shorter chunks and give yourself breaks. Cut yourself some slack.
That's good advice for lots of people on lots of things.
Mm-hmm.
So I want to thank you so much for sharing all of this important information, for normalizing it. One of the things that I appreciate most from this conversation and your presentation is that you did take the research with the logical and anecdotal pieces and you put them together, because there's what is best practices and then there's reality. And so giving our community that ability to kind of look at both sides and then see how it comes together, I think that's really important. So thank you so much for joining us tonight and for doing all of the work that you're doing. Of
course, happy to be here. Have a good evening, everyone.
Take good care. And thank you to Sabina and the Cancer Wellness Center for partnering with us tonight. We appreciate everybody asking such great questions and continuing to help one another. We all know that together we can make a difference in each other's lives. And if you're catching this on the replay, be sure to write replay in the comments and ask your questions, and we'll get back with you. We'll reach out to Dr. Dixit and get back to you on your questions. And I wanted to see if you knew that you can listen to past Wellness Wednesday episodes as a podcast. All you have to do is search Wellness Wednesday or Ralph Foundation on Apple Podcasts, Spotify, or wherever you get your podcasts. We'll be sharing details about next month's Wellness Wednesday session soon, so please keep an eye out on our social channels. We'll be posting it there. And if you have ideas for future Wellness Wednesday topics and speakers, please email us at info@ralphfoundation.org. Don't forget, register for Dash for Detection. It's coming up. On behalf of everyone at Ralph Pancreatic Cancer Foundation and the Cancer Wellness Center, we so appreciate you joining us for tonight. And until next time, stay healthy and take good care. Good night.